hear about the wonderful results they've been getting. Alan.
Jane, thanks for that lovely introduction, and thanks to ProVeg for organising this incredible event. I'm delighted you're all here. And ProVeg have very kindly put a spotlight on gut health today. So I hope I can get you all through the next half hour just talking about gut health. Sorry, you guys all had your lunch. So I'm Dr. Alan Desmond. I'm a consultant gastroenterologist. I'm an advisory board member for Plant-Based Health Professionals UK, so Google those words if you don't know our website. I'm the lead for treating inflammatory bowel disease at the NHS hospital that I work at. Oh, thank you. I've got a small private clinic. You find me online, or the easiest way to get me is just on Instagram at Devon Gut Doctor. So you need to follow up and get any info from me. That's the easiest way to reach me. Just get straight into it. We've been hearing today about the impact of diet, and that's what I'm going to talk about today, but specifically around gut health and Crohn's disease specifically. Now, over 100 years ago, Thomas Edison predicted that the doctor of the future would give no medicine, but that we'd just instruct our patients on the care of the human frame in diet and in the cause and prevention of disease. But here we are over a century later, and we've completely failed to deliver his vision. And as we've already heard today, thanks to the standard Western diet, food is now moved from being an essential sustenance into the single biggest contributor to chronic disease and premature death. Now, we've heard a lot today, as we always do at these conferences, about obesity and type 2 diabetes and heart disease and kidney disease. And those things are really, really important. But I was so pleased to see Crohn's disease and inflammatory bowel disease mentioned today. And because I think this is one of those conditions that should be right up there on that list, these diseases of the standard Western diet. So what is Crohn's disease? So Crohn's disease is a form of inflammatory bowel disease. People who have this condition have sections of their bowel that are red and sore and inflamed. And we see those sections of inflammation in the small intestine and or in the large intestine predominantly. And the gut doesn't just get inflamed, it gets narrowed down, and the inflammation doesn't just stay in the gut. In 1 in 5 people, it goes beyond the gut. They get abscesses in their tummy and elsewhere. And as you can imagine, the bowel doesn't look very healthy. So don't look at this if you find it, a bit gross. But this is what I see. So when I do a camera test and I look inside someone's living gut, when it's healthy, this is what I should see. Nice and smooth and pink, a little bit like the lining inside your cheek, actually a lot like that. But in someone with Crohn's disease, it's inflamed and the lining is ulcerated and it's edematous and it's just not functioning. So you can imagine what that does to your quality of life. People with Crohn's disease get abdominal pain, diarrhea, they've got weight loss, they've got malabsorption and what we doctors call failure to thrive. Their quality of life is terrible. And it's not surprising that people with Crohn's disease tend to miss time at work or miss time at school. And most patients with Crohn's disease would not describe themselves as having good health. We usually diagnose Crohn's disease in young people. So it's usually the median age of diagnosis is 30. So these are people who are in their kind of young, productive years. They've got a new job. They've got a young family. They've just got a mortgage. They're healthy people. And then they've got this to deal with. And a diagnosis of Crohn's disease is bad news. Only 10% of our patients achieve long-term and sustained remission with current treatments, and half of our patients within 10 years are going to end up having surgery to remove part of their diseased gut. Not a nice thing to be diagnosed with. Now, when I was at medical school, we were taught that Crohn's disease is like the classic gastrointestinal autoimmune disease. There's something wrong with your genes, so your immune system is attacking your gut. There's nothing we can do about that, but we've got loads of medications to make it better. So, like a lot of these lifestyle or Western diseases, the genetic story was oversold to me at medical school. Here's a paper from 2016. These geneticists did a complete genetic analysis on 30,000 patients with inflammatory bowel disease from around the world. And these geneticists who spent all that time and money and effort doing that research, even they said in that paper when they published their results, the genetic variants studied here have a small effect. Environmental factors, including diet, are more important. And of course, it's not just genetics, because if it were just genetics, then why did this previously rare condition explode in the Western world in the latter half of the 20th century? Right now, in countries like the UK, about 1 in 300 people have Crohn's disease. In fact, new figures just out last week suggest it's as common as 1 in 200. That's really common. You probably all know someone who has Crohn's disease. And when we look at newly industrialized countries like Brazil and Taiwan, we see that as they industrialize their food system and westernize their food system, they start to see this disease. So a more accurate description of Crohn's disease is this description that I've taken from Current Opinion in Pediatrics 2 years ago, a multifactorial disease caused by an unregulated or dysregulated immune response to intestinal microbes resulting in chronic intestinal inflammation. Okay, that's quite a mouthful, but that's a more up-to-date definition. So here's some healthy gut lining on the left here. These cells are the enterocytes. They separate what you eat from your body. They're all stuck together nice and tight. They have a layer of mucus protecting them. The surface is actually sterile, and your immune system is waiting in here to react to any invaders that are coming in to cause any problems. On the right-hand side, this is Crohn's disease. The mucus layer is diminished. The endotoxins and food particles and bacteria are sticking right on to the previously sterile gut lining. Stuff is getting in and your immune system is trying to handle it, causing inflammation and damage, and that's where the damage comes from. And all our medical therapies target this. We've got a lot of medical therapies for Crohn's disease, and I prescribe them all the time. They're a very useful tool that I've got in my toolkit for making my patients better. But when I go and I look at the studies that convinced me to use these, the results are disappointing. So here are lots of different medications that I use and prescribe all the time. Just going to pick one here, infliximab. It's been around since the 1990s. If you have Crohn's and you start on this, after 4 to 6 weeks, you've got a 1 in 3 chance of being in remission. And if you go into remission, you've got about a 1 in 2 chance of still being in remission 12 months later. So the drugs help, but what I see here is what reflects my practice, is that even with the best medications, patients are still having to live with symptoms and active disease. Now, since I started as a gastroenterologist, even when I was not a gastroenterologist, and I was thinking about becoming a gastroenterologist, I realized that every patient, after you explain this diagnosis to them, inevitably, every single one of them will ask you, what about diet, doc? What can I eat? What should I eat? And they're not just asking what should they eat today so that they feel better today. They know this is bad news. They know they're going to have this disease for years. They want to know, is there anything I could be doing now with my diet to protect myself for the future? And I've just made it my mission to have evidence-based answers. So I found evidence-based answers in the same journals that publish the stuff about the drugs and the surgery and all the other tools I use to treat my patients. So what do we know? Let's just take a little tour of the evidence briefly. We know that eating plants protects you from developing Crohn's disease. Plants, fiber. In the Harvard Nurses study, women who consumed the most fiber had the least risk of developing Crohn's disease. And that applies to children too. Nice study from Canada. They just looked at their kids with Crohn's disease versus healthy kids who didn't have Crohn's disease, and their diets were completely different. High intake of fiber, veg, and fruits seems to significantly reduce one's risk of developing Crohn's disease. So there we have an observation. So when we have an observation, do we have a mechanism that might explain it? We have loads of mechanisms. We know that fiber reduces inflammation in the gut. Fiber, microbiome, available carbohydrates, these things get metabolized by your gut microbiome into short-chain fatty acids. These short-chain fatty acids reduce inflammation, targeting the same pathways that we're trying to target with our drugs. We know that fiber helps to maintain the gut barrier. We'll talk more about that in a moment. And of course, fiber content of your diet is just a marker for how much fruit and veg you're eating. So you're getting all the phytonutrients and the antioxidants, etc. There's plenty of reasons why fruit would be protective. Most gastroenterologists, this is the extent of the dietary advice they give their patients with IBD. Low fiber diet. The logic is, I think, you've got diarrhea, I'm going to make you constipated, you're better. That's it. That's as far as the thinking goes. But in fact, there's no good evidence for the low-fiber diet. I think maybe it has a place, but in a tiny minority of cases. For most patients, they do better with fiber in their diet. And we've seen studies that pitched low-fiber, high-fiber against each other, no difference whatsoever, no benefit, I should say, whatsoever. And we've seen studies where people are asked to eat a little bit of fiber, gradually introduce it, and it reflects what I see in my practice, is that they get better and it reduces their symptoms and they feel better for it. Here's a really nice study. Here is a section of human gut from someone who's had surgery because they've got Crohn's disease. A little bit about the microbiome. You've got a bug in your microbiome. If you've got Crohn's disease, you've got a bug in your microbiome that we don't see in healthy people. We don't even see it in ulcerative colitis. It's called adherent invasive E. coli. Okay? So if you've got Crohn's disease, this bug sticks onto your gut lining, gets self-transported in, and triggers inflammation. So what happens if you take gut from someone with Crohn's disease and the adherent invasive E. coli is invading, and you expose it to broccoli and plantain? Well, guess what? You reduce that process by 70% almost immediately. And if you take the same system and you expose it to emulsifier, polysorbate 80, which is in processed meats and it's in junk food and soft-serve ice cream and a lot of vegan junk food, what happens? Increased twofold, doubles this disease activity. This is a lovely study. I was just saying yesterday that I've got to go and visit this lab sometime. They've got this SHINE system, which is like a stable human gut microbiome in a tank. And they can do whatever they want. They can put anything in there and see what happens to the human gut microbiome. They expose this to emulsifiers like carboxymethylcellulose and polysorbate 80. And what they find is that dietary emulsifiers directly target the intestinal microbiota, increasing its ability to penetrate the mucus and to cause intestinal damage. And it's not just the emulsifiers in our processed food. Maltodextrin, an artificial carbohydrate that's made in a factory and added to processed food to make it taste nice, does the same thing. These are human gut cells. The red stuff is the nasty bacteria sticking on. You put some maltodextrin in and look, way more nasty bacteria sticking on. And you can buy maltodextrin if you want. They sell it as a high energy carb supplement. But you don't have to buy it because 98% of Americans are consuming maltodextrin every single day. And I'm sure it's the same right here in the UK. In fact, the evidence on emulsifiers and food additives is so convincing that in 2013, these scientists charted emulsifier consumption versus Crohn's disease, and they wrote a letter to the Journal of Crohn's and Colitis saying, "We've cracked it. Crohn's disease is caused by food additives." And they were partially right, because what else do we know? I talked earlier about countries westernizing their dietary habits, and then they see Crohn's disease. Well, this happened in Japan from the 60s to the 80s. And these researchers charted it, and they found that animal protein consumption independently it was independently associated with the development of Crohn's disease. And plant protein consumption, the opposite. Increased dietary intake of animal protein may contribute to the development of Crohn's disease, but plant protein seem to reduce it. Of course, that's fruit veg. We don't have to go all the way to Japan for that evidence. Here's a paper from France looking at the same thing. And in this study, 67,000 people followed for 10 years. And the women, because all women in the study, who consumed the most protein were the most likely to get Crohn's disease and inflammatory bowel disease. The women who were consuming 2 grams per kilogram of protein tripled their risk of inflammatory bowel disease. And again, the positive association was restricted to animal protein intake. Veggie protein did not increase the risk. So we've got all these observations. What are the plausible mechanisms? Well, I'm not going to go through this whole slide, so you've heard all about it today. Animal protein, meat and dairy are packed with these pro-inflammatory substances. So of course they're going to lead to an element of gut inflammation. And we've had multiple studies looking specifically at Crohn's and IBD, showing that animal fat and dairy fat can promote this inflammation by multiple mechanisms. And I've mentioned some of these already. Here's a study, Harvard researchers 2014. They weren't IBD researchers, they were microbiome researchers. So they put healthy people on an animal-based diet, the carnivore diet, okay, just all animal products all day long. And within 4 days, they saw an outgrowth of microorganisms capable of triggering IBD, inflammatory bowel disease. So you go carnivore, your gut microbiome starts changing day 1, and the changes are not good. So it took me a long time to read all these papers, and they keep coming out, and I've just showed you some of them. But what it led me to recommend to my patients when they said, what about food, doc? What will I do with my diet? I had this good list and this bad list. Processed food, animal protein, animal fat, dairy, emulsifiers, junk foods, food additives, bad. Whole foods, fruits and vegetables, legumes, plant-based sources of omega-3 and whole grains, good. So before I'd even heard of Dr. Greger, with respect, or Dr. Clapper or Dr. Bernard, I was recommending a whole food plant-based diet to my patients with newly diagnosed inflammatory bowel disease. Does it work? I have time for one case study here. Again, sorry for the icky picture. So Kay was 35 years old when she came to see me in April. She had horrible digestive symptoms. She was running to the loo 9-10 times a day. She was anemic. Her stool sample showed a lot of inflammation. Fecal calprotectin 254, that's high. So I did what gastroenterologists do. I did a colonoscopy. And this is a section of her bowel, and it's red, and it's sore, and it's inflamed. And this didn't happen that week. This is fibrosis. This has been going on for a long time. So she was unwell. Her quality of life was terrible. She was anxious. She needed to know where the bathroom was at all times. She was off work, and she was a self-employed business coach, so she had no income. And her symptoms were severely active, and her quality of life was terrible. So I put her on standard medical therapy with a little bit of steroid, and I started talking to her about her diet. And at that time, she described her diet as ready meals, junk food, and meat all day. She heard my message, but not all of it. And she then described her diet as junk food vegetarian with fish, dairy, and eggs. And between her junk food veggie diet and my azathioprine and methotrexate, so powerful drugs, we got her from severely unwell to moderately unwell. Although her fecal biomarkers were even higher, suggesting more inflammation, and worse than that, she was getting a lot of symptoms from the medications I prescribed, nausea and fatigue. And with the methotrexate, she was getting so sick that she needed to take an anti-sickness tablet to treat the sickness she was getting from the tablet that I was prescribing to make her bowels better. So just look at those pictures on the top left. That's her most recent colonoscopy. Because when she came to see me in February of this year, and the purpose of our discussion was to talk about starting a new medication, she said, I don't need your new medication. In fact, I stopped the other medication because I went whole food plant-based. I did it in January. So she finally heard the message, and she went whole food plant-based. Her fecal calprotectin was normal. I did an MRI scan, couldn't find any inflammation. Did a colonoscopy. You just trust me, this is normal. Okay, this nice, healthy pink tissue is normal. And under the microscope, we could barely even find Crohn's disease. She's got better energy, better sleep, better skin quality. Her dandruff resolved. That's been really important for her. Her dandruff's gone. And she's back at work full-time with enthusiasm. Her symptoms are gone, you know. And she keeps coming to see me at clinic. I see her every 3 months. And we do the stool work, we do the blood tests. And if she gets a flare, I will treat it. I will use medication, and we make sure her diet is dialed in. But without that change in diet, I don't think she'd be where she has been for the last 10 months with no medication. Why does this work? Well, we know that a diet that restricts animal protein and animal fat and N6 polyunsaturated fatty acids and dairy and emulsifiers and food additives and provides some dietary fibre is just a really good way to eat if you've got inflammatory bowel disease. And that's a whole food plant-based diet in a mouthful. Here's a paper, I'm going to show a paper in a moment, where they were aware of all this research, so they took young people with Crohn's disease and they put them on a diet that did all of this, but they let them have a little bit of chicken and a small amount of fish. But in order to reduce that exposure even more, they gave them half their calories from something called enteral nutrition. Enteral nutrition is like the space food that we use in gastroenterology. It's the building blocks of nutrition. It's the molecules that make up carbohydrates. And it's amino acids rather than protein. So it gets absorbed really high up in your gut, so the bits of your bowel that are affected by Crohn's disease don't even see any food. That works too. But they put people on this dietary plan that met these requirements and the drink for half the calories to push their exposure down even more. And within 6 weeks, 80% with good clinical response, 70% in complete clinical remission. Now compare that to what I showed you earlier with medication. There's no medication in this study. And they stayed better out to 3 months, which is how long they followed them. They came back a few years later and used the same regimen for patients who'd been around the block a couple of times. These were older people who'd been on all the immune suppressants. Some of them were on infliximab and other drugs, and they still weren't getting better. These are patients who are really difficult to get better. And what happened? 90% much better at week 6. 62% in complete clinical remission at week 6. Those are great numbers. And interestingly, 18 patients wouldn't take the drink, they just did the whole foods, and they did even better. So what happens if you take someone with Crohn's disease and you get them into remission using standard medical therapy, and then you ask them to eat a plant-based diet? This study from Japan, 2010, Professor Chiba and his team, 32 patients, they used a standard therapy to get them into remission, and then asked them to eat a plant-based diet. Long-term remission rates better than any reported drug trial in Crohn's disease. 100% in remission in 12 months. And of the people who reverted to the standard Western diet, which they were all at before they came into hospital with Professor Chiba, after 2 years or 1 year, we see 66% of them having a relapse. And that's what we expect to see. Small numbers in the relapse arm of that study, but that's what we expect to see in the standard Western diet. Here's a study that was just published a few months ago. The title of the study is completely misleading. A diet low in red and processed meat does not reduce rates of Crohn's disease flares. United States study, really well designed, very nicely recruited. 200 patients with remission of Crohn's disease followed for 12 months. What did they do? Did they put on a whole food plant-based diet? No. They just said, could you eat less meat? That was it. That was the intervention. The intervention failed in both the high meat arm and the low meat arm. Everybody was eating 30 to 40 grams of animal protein per day, 20 grams of plant protein per day, and a miserable 17 grams of fiber per day. And guess what? They were all eating a standard Western diet. They all did really badly. 62% of them had a relapse at 12 months. Compare that to the slide I just showed you a moment ago. If you know someone with inflammatory bowel disease, or you've got a gastroenterologist, please take a picture of this slide. Because doctors love evidence. This is a paper published in Gut, which is like the Time magazine for gastroenterologists last year. Okay? It reviews all the stuff that I just showed you. So please, if you know someone with Crohn's or colitis, IBD, get them to look up that URL. And then get them to look up this URL. So this is a case report that I was delighted to publish with Neil Bernard and Hannah Kaliova, a PCRM, just a few months ago in the journal Nutrients. It's a different patient story, another very similar patient story, but it also reviews all the evidence, all those papers that I just mentioned, and more. My hospital is really interested in what we can do for our patients with Crohn's disease if we give them evidence-based medical therapy and evidence-based dietary advice. So we're embarking on a clinical study where we're going to take our patients with Crohn's disease and put them on a whole food plant-based diet. And we'll be following them really careful to see how they get on. And I hope to present this data at ICNM in Washington in August 2020 with Dr. Bernard and his team. So I'll expect to see you all there in Washington, D.C. in August. So this story is very much to be continued. Thanks very much for listening. Please Google Plant-Based Health Professionals UK and find me on Instagram if you've got any questions or you want me to just send you those resources that I mentioned. Thanks very much.